Good morning, doctors and professors. Thank you very much for attending the APASL 2024, the Center of Hepatology. Now, we'd like to start our conference program. The first session is a state-of-the-art lecture chaired by Dr. Han-Jin Lee. Dr. Lin, please.
Good morning, everyone, ladies and gentlemen. I'm Dr. Han-Jin Lee from Taipei, Taiwan. It's my great pleasure to welcome all of you to this symposium regarding the MAFLD. Fatty liver disease currently is the name of a steatotic liver disease, is getting more and more prevalence and lead to a majority of the lot of the liver and the non-liver related event, and that's cause the public health burden. So today we are very happy to invite Professor Jacob George, who is an expert in this area. Professor George is the professor of hepatic medicine at the Store Liver Center, Westmead Institute of Medical Research, University of Sydney. He is also the head of Department of Gastroenterology and Hepatology at Westmead Hospital. So let's welcome Professor George to give his top about MAFLD from concept to clinical practice. Jacob, please.
Thank you very much, Professor Lin, for that kind introduction. And thank you to all the members of the audience who braved, perhaps without breakfast, to come and listen to this lecture. And when they actually asked me to give the state of the art, I was thinking of a suitable topic. And what I decided to do was really talk about the evolution of fatty liver disease and MAFLD, and I've titled it From Concept to Clinical Practice. Now, the start of the journey back in 2019, these were our operational realities. What was known all over the world, including in my own home country of Australia, was that most patients presenting with fatty liver disease to primary care have undifferentiated disease. Now, what do I mean by undifferentiated disease? They usually have slightly abnormal liver tests. They turn up to the primary care physician. He has no idea what they have. Is it alcohol? Is it drugs? Is it statins? Is it fatty liver disease? He has no idea. The second operational reality was that the vast majority of patients will need to be managed in primary care. Now, Australia actually has a large number of primary care physicians per head of population. We've got about 300 doctors, one doctor for 300 patients. But if you actually look at the global prevalence and the Australian prevalence of fatty liver disease, and you divide it by the number of doctors, if every MAFLD patient was referred to a specialist, every gastroenterologist would have 10,000 cases. So clearly, anywhere in the world, this disease burden cannot be managed in tertiary care. It has to be managed by and large in primary care, with the appropriate patients being referred to tertiary care. The next operational reality was that primary care is not equipped for extensive investigations to diagnose the old disease, which is non-alcoholic fatty liver disease. And that's because there are quite a lot of tests to be done before you diagnose NAFLD. The fourth reality was the vast majority of the global population and most physicians, primary care physicians, don't have the tools to diagnose NAFLD, because to diagnose NAFLD, you have to exclude everything from Wilson's disease to celiac disease to hepatitis B and hepatitis C. We also know that alcohol-related liver disease is common in all parts of the world. And I've had plenty of beer and sake in Japan. And the final reality was that apart from hepatitis B and hepatitis C, other liver diseases that a GP, a primary care physician, might see are pretty rare. Now, this is a slide actually illustrating how ubiquitous alcohol consumption is and how difficult it is to diagnose alcohol-related liver disease in the clinic, or for that matter, non-alcoholic fatty liver disease. This is a very nice study done in Austria, 184 patients. They've got an alcohol-related liver disease clinic, and they also have a non-alcoholic fatty liver disease clinic. And what was different in this particular study is that they had some hair samples from every patient, and they measured hair levels of ethyl glucuronide, which is basically a metabolite of alcohol, and it remains in the hair for at least a couple of months. They did all the other alcohol-related questionnaires, and they looked at moderate alcohol intake, so between 10 grams to 60 grams per day. And what was amazing is that in this population, diagnosed in a NAFLD clinic and seeing doctors with a presumed diagnosis of NAFLD, about a quarter, 1 in 4 people actually were having hazardous consumption of alcohol. So it really became clear to us that if you're actually going to talk about this disease, you have to acknowledge the reality. A lot of our patients drink, and there's a lot of recall bias, or they try and minimize their symptoms. So what we realized we needed to do was to diagnose the actual disease that we wanted to diagnose, irrespective of the presence or absence of other liver diseases. Now, just going back to pathophysiology, as most of you know, reduced insulin sensitivity with compensatory islet cell, beta cell production of insulin, which therefore gives you a raised C peptide, is the basis for insulin resistance. And insulin resistance is fundamental to the pathogenesis of type 2 diabetes. The vast majority, in fact, if you do sensitive enough tests, every patient with type 2 diabetes will have underlying insulin resistance. And over the last 40 years, apart from understanding insulin resistance, there's been the diagnosis of what used to be called the insulin resistance syndrome or the metabolic syndrome. And for the metabolic syndrome, and this is very important to actually understand, when they came up with the insulin resistance or metabolic syndrome criteria, they said you need 2 or more criteria. One criteria had a very poor relationship with the presence of insulin resistance, which is the underlying pathophysiology. And so if you look at, say, low HDL or diastolic hypertension, the relationship with insulin resistance, the core pathophysiological abnormality, is very low. And as you know, it's linked to a whole lot of conditions, including polycystic ovary disease. So this was really a seminal study that we published back in 2002. If I had published or tried to publish this study, there's no way it would have been published. And currently it is it is the bedrock for all the studies on fatty liver disease. And so we just had 65 patients, and we just did a very broad test, a HOMA insulin resistance test, which is looking at fasting glucose and insulin divided by 22.5. And we showed that basically 65 of 66 patients, in other words, virtually everyone had insulin resistance, and 90% of them fulfilled the insulin resistance syndrome criteria or the metabolic syndrome resistance criteria. So the implication that we knew back in 2002 was that insulin resistance is universal in metabolic steatohepatitis. If you have no insulin resistance, you don't develop metabolic steatohepatitis. And so the last conclusion you could make from that study was that the treatment of metabolic steatohepatitis, it's basically metabolic inflammation. You have to reverse the insulin resistance. Now, the next question really is, we published that insulin resistance is important in the pathophysiology. Where does the insulin resistance actually reside in the patient? You can get liver insulin resistance, you can get muscle insulin resistance, and you can also get adipose tissue insulin resistance. Those are the 3 major target organs. And this is a very nice study done by Ken Kuzi, 352 adults. Every one of them had a liver biopsy, a glucose tolerance test, a euglycemic clamp, which is the most sensitive way of actually measuring insulin resistance. And you can actually then separate liver insulin resistance, muscle insulin resistance, adipose tissue insulin resistance. And then he also did magnetic resonance spectroscopy looking for the presence of liver fat. And so I'd just like to now bring you down to the bottom 2 panels. This is liver insulin sensitivity, skeletal muscle insulin sensitivity. On the y-axis on the right-hand side is liver fat, and on the y-axis on the left-hand side is insulin resistance. And so as you will see, as liver fat increases, these are these little black circles here, as liver fat increases, hepatic insulin sensitivity decreases. But after a hepatic insulin sensitivity at 1.5%, any further increase in liver fat is not associated with reductions in hepatic insulin sensitivity. So what it says is that liver fat accumulation is not due to reduction in hepatic insulin sensitivity. The next part is you can look at muscle. And when you look at muscle insulin sensitivity decreases till about 6% liver fat, which is up here. After that, if you get any increase in liver fat, there is no change in muscle insulin sensitivity. So this study clearly tells you that the driver of liver fat in fatty liver disease is not the liver and it's not the muscle. So what is it? And what he was able to clearly show is the strong association of intrahepatic triglyceride is with adipose tissue insulin resistance. So as you will see, adipose tissue insulin sensitivity gradually declines, and there's a nice inverse correlation. As the sensitivity declines, the liver fat actually increases. So we know that insulin resistance is the key to this disease. We know that adipose tissue insulin sensitivity or impaired insulin sensitivity is the driver of liver fat accumulation. And so then when we had all of these concepts back in 2019, we needed to come up with an operational reality with which we as clinicians see patients with fatty liver disease. And we all recognize that 90% of our cases are due to one or two diseases. It's due to so-called NAFLD or alcohol. And so we came up with this particular diagram where this is the secondary causes of fatty liver, whether it's hepatitis C or Wilson's disease or celiac disease. But the vast majority were going to be in this particular group. And so what we decided at our first iteration, we came up with this acronym MPFL, which stood for metabolic dysfunction predominant fatty liver. And in the blue was alcohol predominant fatty liver. And so if you look at this, we then said there are going to be patients with metabolic dysfunction predominant fatty liver with no alcohol or with alcohol. And similarly, if you look at the alcohol group, you've got alcohol predominant fatty liver with metabolic dysfunction or alcohol predominant fatty liver with no metabolic dysfunction. And so what we wanted to really do is to try and look not at the secondary causes, but the vast majority of fatty liver that we see in clinical practice, that group in green. And we needed to tie in our concepts on insulin resistance and insulin resistance driving metabolic inflammation. And it's important to remember again that it's adipose tissue insulin resistance that's the driver of liver fat. The other piece of information that's very, very important and relevant when you look at the development of fatty liver disease is this study published by my very good friend, Paul Angulo. Unfortunately, he died a few years ago from brain cancer. But this is a study that he did with Japanese office workers, and they all have health checks. And when they have health checks every year, they get all these things measured. And then what you can do is to do some interesting statistics and work out the chronology of the development of fatty liver disease. And I think you can use this for every patient that you see in clinical practice. So the first thing that happens in the development of fatty liver disease is your body weight increases. The next thing that happens is if you use the physiological healthy range of ALT, which is 19 for women and 30 for men, liver fat accumulation and elevations in liver fat, in AST and ALT is the next thing that goes up. Then you get atherogenic dyslipidemia with a low HDL and an elevated triglyceride. Then you get hypertension. Then you get your diabetes. Initially, it's compensated and you get insulin resistance. And then you develop frank type 2 diabetes. And then after that, you get your heart disease and you get your chronic kidney disease. So every patient that we see, I actually talk about this metabolic journey, and I try and tell the patient where they are along on this metabolic journey that's driven by insulin resistance, that's causing systemic metabolic dysregulation and dysfunction and metabolic inflammation. So it's a whole of body event. And so these were the underlying concepts that we actually went through when we tried to define this particular disease that we see, and we called it metabolic dysfunction associated fatty liver disease. We also knew that this disease is highly prevalent in all parts of the world. So you need to have a simple definition, and it's got to be positive. So we said, if you have hepatic steatosis and type 2 diabetes, you've got MAFLD. You don't need to think about anything else. It's as straightforward as that. A patient may have hepatitis B, C, alcohol, it doesn't matter. They've also got this disease that we're talking about, which is MAFLD. If you're overweight or obese based on ethnic specific criteria, then you've also got MAFLD. And then if you're of a normal weight, again, it's very important to emphasize the importance of 2 metabolic risk factors, because to get metabolic inflammation and to be sure that you've got metabolic inflammation related to insulin resistance, as the metabolic syndrome criteria says, you need at least 2 of the factors. A single factor in a healthy weight individual doesn't necessarily mean that they've got insulin resistance. And this is why we came up with needing 2 metabolic risk factors. So the criteria are simple, it's positive, it's got nothing to do with any other disease, it's about what this disease is. You can apply it in all income settings, high income settings, low income settings, and it splits people into 3 homogeneous groups. And in fact, the Lancet Commission on Liver Disease back in 2021 suggested that the most appropriate name for this disease should be MAFLD. This was really how we actually designed it. One of the interesting concepts is when you think about any disease, think about heart failure. Now we don't think of just heart failure. We actually think of increasing stratification, normal ejection fraction, elevated ejection fraction, reduced ejection fraction. And exactly as the same, MAFLD actually segregates people into these 3 criteria. So are these 3 criteria of any clinical use to a patient? And this is a great study done from our part of the world, from Korea, 967 individuals, and all of them had MRE-based liver stiffness, the most accurate way of assessing liver stiffness. And you can see the age and gender of the people here. And what they did, exactly as per the MAFLD criteria, they looked at liver stiffness based on weight, so overweight, obese, lean with 2 metabolic risk factors, and then the type 2 diabetic group. And these are just the baseline data. And again, what you will see is while MAFLD was initially a concept, this actually proved that it has clinical utility in terms of segregating our patients, because they have different baseline characteristics of liver fibrosis when you see them. So you can neatly put your patients into each group. Does that actually translate to clinical outcomes? And this is a publicly available database. This is the NHANES database from the US. And what they did was they did exactly using our stratification criteria, MAFLD with type 2 diabetes, those who are overweight and obese, those who are lean with metabolic dysregulation defined by 2 criteria. And they looked at all-cause mortality, cardiovascular mortality, and cancer mortality. And exactly as we would predict, there are actually differences. The highest risk of all outcomes is worse in the type 2 diabetes group. It's intermediate in the overweight obese group. And then it's lowest in the intermediate group, and then it's at intermediate level in the lean with metabolic dysregulation. So again, it shows you how useful this particular criteria are. It tells you something about the baseline. It tells you something about the disease trajectory. It tells you something about the clinical outcomes. Rather than trying to actually lump everything in the NAFLD definition, the old non-alcoholic definition, this actually tells you what happens to these individuals based on this categorization. Now, this is a study that's given by my collaborator Minghua Zheng from Wenzhou in China. And what they did was they looked at 92,000 patients, and they really looked at a whole cohort on the left-hand side and a lean cohort on the right-hand side. And the key message here that I want to show you is that there is a lot of overlap between MAFLD and MASLD, but you can see that if you've got MAFLD, which is these right two bars, there's an increased risk of adverse cardiovascular outcomes, which is MACE, in the MAFLD group. But the MASLD only group, there is no difference from people who don't have fatty liver disease. So that exists in the whole cohort and even in the lean cohort, suggesting the clinical utility of the disease and the stratification for primary care, which patients to refer to tertiary care, and which patients we need to be careful when we look into their management. So this is a study that there's a poster on this that's done by Harry Crane, who works at the Store Liver Center. And what he was looking at was the global prevalence of MAFLD-related HCC. And we looked at about 50,000 patients who were diagnosed based on the MAFLD criteria. They had to have overweight or obesity. They had to have ethnic-specific criteria for that. They had to be lean with 2 metabolic risk factors, or they had to have type 2 diabetes. And when you look at these 50,000 patients, single etiology MAFLD currently is about 12% of the population. Total MAFLD, any MAFLD in the HCC population is nearly half. In Hep C, it's 54%. 40% of patients with hepatitis B have MAFLD, and 64% with alcohol-related disease have MAFLD, suggesting that really when you look at your patients, it's important to diagnose not just your hepatitis B or hepatitis C, but you need to understand if the patient has underlying fatty liver disease. Now, this is the global prevalence of the disease, and as you will see, it's very, very common. The areas such as Australia, Japan, Indonesia, and India, plus many of the countries in the Middle East have a high prevalence of this particular disease. And this is a very recent study published from India last week in APT. And this looked at 6,000 patients from New Delhi. And the highlight figure is that 56% of patients in metropolitan India have fatty liver disease. We've got 60% of the global population. This is going to be the sleeping giant for all the adverse liver outcomes that we're going to see. Now, while it's important as hepatologists that we all think of fatty liver disease and the liver-related outcomes, it is very, very important that MAFLD does not live in isolation. There is a tsunami of competing risks that you have in your patient. So this is looking at the global burden of disease study, 68 million adults, and looking at BMI and its contribution to death on the left and disability-adjusted life on the right-hand side. And if you look at the causes of death, if you just focus on this, what are our patients going to die from if they have MAFLD? The vast majority will die of cardiovascular disease, some will die of cancer, some will die of chronic kidney disease, and some still will die of type 2 diabetes. Liver disease doesn't even rate a mention. So it is not good enough that we actually think of a patient's liver. We got to think about the patient as a whole, because the patient has metabolic inflammation. It's not just liver inflammation. This is another study that actually highlights the same data that was published this year by us. And in Australia, if you have type 2 diabetes and you get a glucometer, you're automatically registered onto a national database. So we know every patient who's got type 2 diabetes. And then we can link it to death records. And so this looked at 1.1 million Australians with type 2 diabetes. And we looked for all liver diseases. And when you looked at the causes of death in diabetic patients, only less than 2% died from every combined liver disease together. And the graph on the bottom shows chronic kidney disease deaths. Cardiovascular deaths will be up here. And you can see that liver-related deaths, all liver diseases in type 2 diabetics, 1/3 the frequency of chronic kidney disease. And when you look at the types of liver disease that these patients had hospitalizations for, 1/3 was actually due to alcohol-related liver disease. And then finally, when you look at diabetics and look at the risk of hospitalization, yes, there was an increased risk of hospitalization in the diabetics if you had fibrosis or cirrhosis being the cause of your hospital admission. But guess what? It only accounted for 25% of excess hospital admissions, 25 excess admissions per 100,000 people. So yes, the problem we have is we've got only a small number of doctors that have got a special interest in liver disease. So it is still a large burden for us, but really the metabolic inflammation is a systemic disease. We know how to actually treat this disease. We know that weight loss in this landmark study by Villar Gomez in 2015 shows the more weight you lose, you have more steatohepatitis resolution and more fibrosis improvement. So lifestyle intervention has to be the core. But I think it's very, very important to understand that this has to be holistic. And this is going to be published in our MAFL supplement in Hepatology International in the next 3 months. But you need to think about a 24-hour clock. So you need to think about sedentary behavior. Prolonged sitting for more than 8 hours is detrimental to your health. You need to be thinking of physical activity and exercise. You need to be thinking about daily steps, and just adding 2,500 extra steps reduces your risk of MAFLD by 47%. Getting adequate sleep, 7 to 8 hours, is important. Good diet quality. Coffee seems to not do any damage, and it may in fact be good, but that's all cross-sectional studies. And smoking and alcohol are important. So managing patients at a cornerstone is about this 24-hour clock that we should be doing. We've also now got very, very good therapeutic armamentarium for the management of weight. So yes, the baseline for most of the patients is lifestyle and behavioral changes that I talked about on the previous slide. For some patients with obesity specialists, you can do VLCD, the very low caloric diets. Now we've got anti-obesity medications that can give you weight loss depending on the drug you choose from 10 to 25% reduction. And then we've got bariatric surgery. So we've now got step therapy for weight management. We've also got drugs that are now entered into clinical trials. This is the semaglutide, a phase 2 study with daily injections. And as you will see, the primary endpoint was resolution of steatohepatitis with no worsening of fibrosis. And all 3 doses of the daily injections actually met the steatohepatitis resolution landmark. But the more important benefit of GLP-1 receptor agonists is looking at all the studies predominantly done in diabetes, obesity, and for cardiovascular disease, and all of them show a reduction in MACE events. And as I said, MACE events is what kills most of the patients. There's been a lot of excitement about resmetirom, a thyroid hormone beta agonist. This is the data that was published in the New England Journal of Medicine. As you can see, there was significant NASH resolution at both doses, the 80 and the 100 milligram, improvement in fibrosis, and it reduced atherogenic dyslipidemia. And on the basis of this, as you know, on March 14th, the FDA gave accelerated approval for resmetirom. But remember, it's in conjunction with diet and exercise for the treatment of adults with non-cirrhotic metabolic steatohepatitis with F2 and F3 fibrosis. This is another drug, which is the FGF21 analog. the Harmony trial, and this looked at week 24 biopsies. This is a phase 2 study. It's gone into phase 3, and they've also done liver biopsies at phase 2. And very excitingly for us in this F2, F3 group, the FGF21 analogs both do MASH resolution and fibrosis improvement. And when you look at the week 96 biopsies, again, you can see the highest dose, the 50 milligram dose in the patients who had dual biopsies was 75%. So clearly, very, very promising results. Apazil has got its own clinical practice guidelines, and in the next 4 months, the second iteration of the Apazil guidelines will be available. So just to conclude, Mr. Chairman, ladies and gentlemen, looking at the MAFL journey from concept to clinical practice, I believe it is an innovative concept that integrates operational clinical realities. It's based on pathophysiology. It segregates people into 3 homogeneous groups with distinct presentations, trajectories, and clinical outcomes. It's a highly prevalent liver disease, and it will be the disease in the century, and particularly in the Asia-Pacific. It aligns and unifies through insulin resistance and metabolic inflammation all other non-communicable diseases. There are now a large number of therapeutic options. The cornerstone is holistic lifestyle intervention. We've now got a good armamentarium of options for weight management. We've got GLP-1 receptor agonists that reduce extrahepatic events. We've got other type 2 diabetes drugs that hold promise for liver fat reduction. We've got the first FDA-approved drug in terms of resmetirom, and the CPG guidelines from Apazil will be available in a few months, and otherwise you can look at the last one from 2020. So thank you very much.
Thank you very much for Professor George's very comprehensive review. And as usual, you know that there's no Q&A in the state of our lecture. So this session is closed here. And thank you for coming to the very early morning state of our lecture. Thank you, Professor George.
Thank you very much, moderators and lecturers. The next program session is chaired by Dr. Shuntaro Obi. Dr. Obi, please.
Good morning, everyone. Welcome to Kyoto, and welcome to state-of-the-art lecture. Today, we invite Professor Kiyoshi Hasegawa. I am pleased to introduce Professor Kiyoshi Hasegawa of the University of Tokyo. After graduating from the University of Tokyo, Dr. Hasegawa became a trainee of Dr. Makuchi and continued his studies. Dr. Hasegawa's outstanding skills and many accomplishments led him to become a professor at the University of Tokyo. He currently holds leadership positions in many medical societies as well as university work. As you know, liver cancer is very common in the Asian region. Unfortunately, many patients are found to have advanced cancer. In this lecture, Professor Hasegawa will show the current role of surgical resection using the recent advanced systemic therapy for HCC. Dr. Hasegawa, please.
Good morning, everybody. Thank you, Professor Obi, for your kind introduction of me. And I express my sincere thanks to Professor Sina, Congress President, for giving me to this opportunity to the presentation. My topic is about the surgical resection following the systemic therapy for advanced hepatocellular carcinoma. As you know, the advance of systemic therapy for hepatocellular carcinoma is very remarkable. So liver surgeons, including me, should consider how to combine the systemic therapy to surgical treatment for HCC. So I will show the results of clinical trial, prospective clinical trial organized by my study group, and also discuss about significance of combination of systemic therapy and surgical treatments. I will show the COI. The surgery is the only choice for cure of patient with advanced hepatocellular carcinoma. However, surgery is not performed in most of the patients because of extensive vascular invasion, intrahepatic metastasis, extrahepatic metastasis such as advanced hepatocellular carcinoma. There are only a few reports about conversion and combination therapy using the systemic therapy and cancer drugs. According to the guideline worldwide, for the advanced stage HCC, only a systemic treatment has been recommended. But the long-term outcomes provided by systemic therapy is not so satisfactory. The MST obtained by the sorafenib was only 10.7 months, and the atezolizumab bevacizumab combination therapy as a standard treatment, the first choice of systemic therapy, provided only 19.2 months of median survival time. In Japan, liver surgeons had aggressively performed the liver resection for the advanced hepatocellular carcinoma. This study was performed using the big data by the nationwide survey of the liver cancer study group of Japan. You can see the overall survival curve after liver resection for the HCC with portal vein tumor thrombosis was much better than the results of a non-liver resection group. The 5-year overall survival after liver resection for HCC with the portal vein invasion and the child PUA liver function was more than 40%. And the similar study was also done using the same data for the HCC with hepatic vein tumor thrombosis. The long-term outcomes after liver dissection for HCC with VB12 was very good. MST was 4.47 years, which was much better than the MST of 1.58 years provided by the non-liver dissection group, non-liver dissection. We want to mean that the presence of hepatic vein tumor thrombosis in the liver. However, as for the VB3, meaning that the presence of hepatic vein tumor thrombosis outside the liver, such as IBC and the right atrium, the MST was not so high after the liver resection, 1.48 years. There is a significant difference between the MST between the liver resection and the non-liver resection, but MST itself is not so good. So I think the HCC with VB12 is candidate of liver resection, good candidate of liver resection, but liver resection is not so recommended for the HCC with VB3. These retrospective studies show the usefulness of effectiveness of liver resection for advanced hepatocellular carcinoma. But to improve the survival after liver resection for such kind of advanced hepatocellular carcinoma, we have to consider the use of systemic therapy combined with surgical resection. The global phase 3 study, REFLECT trial, demonstrated the non-inferiority of lenvatinib against sorafenib for the treatment of patient with unresectable advanced HCC in terms of overall survival. So we conducted a prospective multi-center single-arm trial to investigate the significance of the lenvatinib therapy for initially unresectable advanced HCC. This is a study designs of the LENS trial. The targeted population was set as the patient with initially unresectable advanced HCC. After obtaining the informed consent, we registered such kind of patient to this trial and introduced the lenvatinib therapy. Every 4 weeks of lenvatinib therapy, we evaluated the resectability by the enhanced CT scan or MRI. If resectability is expected, we perform the surgical resection. Before starting this trial, we thoroughly discussed about the definition of resectability, unresectable, but we could not reach a clear definition of unresectability. So we defined 5 subgroups as inclusion criteria of LENS trial. Total 5 subgroups. Type A was presence of intrahepatic vascular invasion. B means synchronous extrahepatic metastasis. C was a combination of type A and B. D means macroscopic residual tumor, and the last one, type E, means metachronous extrahepatic metastasis. We reported preliminary results of this trial 2 years ago, and recently the result of this study was accepted in the liver cancer. This is a flowchart of the patients registered into the LENS trial. The total 49 patients were finally registered to this trial. Among them, the lenvatinib therapy was completed in 37, interrupted in the 11 patients. The total 33 patients underwent surgical resection, not performed in 15 patients. This table summarizes baseline characteristics of the 49 patients registered into this trial. The median age was 71. The median ICD value was 14.5%, suggesting the most of the patients had slightly deteriorated liver function. The registered patient had advanced hepatocellular carcinoma, so the tumor markers AFP and DCP were very high. Among the 49 patients registered to this study, the type A was 32 patients, 65.3% in the total registered patients. And type C was 1 patient, so about 70% of the registered patient had macroscopic tumor tumors. We evaluated the liver function, measured the ICG R15 before and after lenvatinib therapy. The value of ICG R15 were almost similar with before and after lenvatinib therapy in the most of the patients. This table summarizes the surgical outcomes in 33 patients undergoing the surgical resection. Liver resection was performed in 29 patients, about more than 80% of the registered patient. The median operation time was about 6.5 hours, and the median blood loss was 445. The median postoperative hospital stay was 11. There was no 19-day mortality. This is a overall survival curve after the registration to this trial. The follow-up period was not so sufficient. The data about the long-term outcomes immature at this time, but 1 year survival rate was 75.9%. The median PFS was not so good, only 7.2 months. There is this discrepancy between the good overall survival and poor PFS. If the patients were divided into the resected group and unresected group, the long-term outcomes of resected group was very good. Of course, there is the big bias between two groups, but I can say if the resection was achieved, the overall survival would be better. We in our group, study group, we discussed about the result of the study. But the most important question was, why was the resection rate so high? Maybe the cases of a technically resectable but oncologically unresectable HCC were included into this study. So we collected the data additionally about 2 points. How many cases did considered as technically resectable but oncologically unresectable? And what kinds of tumor tumors were included? Among the 49 cases, technically resectable case was 7. Among them, resection was done in only 1 case. Most of the cases, 42, were considered as oncologically unresectable. And the types of macroscopic tumor tumors were like this. There are some overlap of tumor tumors in the portal vein, hepatic vein, and the bile duct. In short summary, in this trial, the resection rate was 67.4%. Macroscopic curative resection rate was 60.4%. The objective response rate was 12.5% based on the RECIST 1.1 and the 37.5% based on the modified RECIST criteria. The liver function were almost similar, evaluated by the ICG test. And this trial, I think, in my opinion, this trial demonstrated the feasibility of a conversion strategy, surgical resection combined with lenvatinib therapy in patients with the initially unresectable advanced HCC. But there are some clinical questions about the trials, result of this trial, such as discrepancy between the good overall survival and the poor PFS. So we scheduled to perform further analysis in this year, 2024. We will collect the data about sites of a first recurrence and therapeutic choices for the first recurrence. So if these data were collected and analyzed, maybe we can answer the clinical question about the discrepancy between the good overall survival and the poor PFS. And this INBRAVE 150 trial provided wonderful results, which demonstrated the superiority of atezolizumab bevacizumab therapy against the sorafenib for the treatment of HCC, a patient with advanced HCC in terms of our overall survival and progression-free survival. So also our study group conducted the similar trial named as RACP trial, multi-center single-arm trial of resection initially unresectable HCC with atezolizumab combined with bevacizumab. This trial is organized by Professor Hatano in Kyoto University, and the registration of the patients was finished, and we collected the data, and I hope we can show the results in near future. By the experience of prospective clinical trials, I think we have to discuss about the advantage and disadvantage of the system therapy followed by the surgical resection. I think there are 4 important points. The one point is the dosing route, oral intrathecal or transvenous route, and time to respond, and waiting period to surgery, and adverse events, especially to the general condition and also to the liver function. And to consider the feasibility and the effectiveness of a conversion strategy, we also have to discuss about several points. Is upfront resection really impossible? And we have to consider the definition of unresectable and borderline resectable. And expectation for the tumor shrinkage, and how long should we wait to consider the resectability during the systemic therapy. So to answer this clinical question, we prospectively collect data indispensable. Recently, in Japan, the liver surgeon have discussed about oncologically resectability criteria for HCC. The expert panel was conducted by the Liver Cancer Study Group of Japan and the Japanese Society of Hepatobiliary Pancreatic Surgeons. We defined the resectable HCC, borderline 1 HCC, and borderline 2 HCC. The concept of these subtypes were like this. Resectable means that oncological status for which surgery alone may offer clearly better overall survival compared to the other treatments. The BR1, borderline resectable one, means that the oncological status for which a surgical intervention as a part of a multidisciplinary treatment may offer surgical benefit. Borderline 2, the borderline resectable 2, nearly equal to initially unsuitable for resection. That means the oncological status for which efficacy of surgery is indeterminate, and the surgical indication should be carefully determined under the standard multidisciplinary management of HCC. Concretely, the R means the single tumor without surgical surgery limit, and the tumor size 2 or 3 within the 3 centimeter in diameter, or the VP01, VP01, and the B01. BR1 included the patient with a multinodular HCC status between R1 and BR2, presence of a BP23, BP2, and B23, or association with localized extrahepatic spreads. BR2 includes a patient with a multinodular HCC, 5 or more nodules, and the 5 centimeter or larger, or presence of a VP4, VP3, and V4, or presence of extrahepatic spreads. In my institution, we have several cases in which systemic therapy and surgical resection was performed for the BR1 HCC. There are 4 cases of the BR1 HCC in which lymphatic therapy was introduced, followed by the surgical resection. Total, among them, we could perform the surgical resection in 4 cases. But among the 4 cases in which atezolizumab bevacizumab was introduced, we abandoned to perform a surgical resection in 1 case. Long-term outcomes were like this. And for the BR2 HCC, we have total 13 cases in which systemic therapy and surgical resection were performed. Total, we performed the surgical resection in 7 cases. Long-term outcomes are summarized like this. These results were preliminary in only a few cases. So we have to collect the data in multi-center. So in my conclusion, everybody, by the remarkable advance of systemic therapy, liver surgeons have to pursue the possibility of a conversion to surgery for the advanced HCC. Clear definition and the prospectively collected evidence data are necessary. Now, the definition of resectability and the borderline resectability advocated. So it would be better to conduct a retrospective and or the prospective clinical studies based on the new definition of resectability and the borderline resectability. Thank you for your attention. Thank you very much.
Thank you for your excellent lecture. Your excellent lecture gave useful information to all APASL members. Thank you very much. So, short question, please.
Thank you, Professor Hasegawa. Nice talk. So, Professor Takayama, he's a very famous surgeon and he has a high quality of skill for hepatectomy. So some years ago, I asked the question about neoadjuvant therapy. So he answered, I dislike neoadjuvant therapies. So I asked a simple question. Do you like neoadjuvant chemotherapies?
In my opinion, I like the chemotherapy or not is not a problem. Only the usefulness of the neoadjuvant or adjuvant therapy should be discussed. Based on the preliminary result of the LENS trial, the effectiveness of lenvatinib before surgical resection is not established, but not so bad. So I hope the effectiveness or usefulness of neoadjuvant therapy followed by surgical resection for advanced HCC had better be evaluated by another prospective trial.
Thank you.
Thank you very much. I would like to close this session. Thank you very much.
Thank you.
Thank you very much, doctors. Now we will have a break. We will start the next session from 9 o'clock. We'll start the next session from 9 o'clock.